Today we're going to show a case. This is a patient with hyperlaxity. They suffered an ACL tear, proximal tear, grade 3 MCL tear, lateral meniscal root tear, so they needed surgery a little more promptly. Hence we needed a more complex repair. You can see here, excellent stump. And you can see here on stressing that's over 6 millimeters of opening. So the decision was to do an MCL repair. Also it had a meniscal root tear. You can see the flap here. Again, this is something you do not want to remove these. Data has shown that repair is a much better option. First, start off with part of the repair. So again, we're going to do a small notchplasty. We're going to remove any of the scarred ACL. You can see that it starts to coil back and then it will stretch out as you pull it up. We're going to do microfracture the notch. This brings in stem cells and egression of further healing potential. And then we're going to do a 4.5 reaming pin. And we're going to go all the way through on this. And this will pass both our button for the repair. And then we're going to work on our meniscal root/radial tear. And we're going to use our ball rasp to irritate that area. We're going to place 2 separate stitches. The first one is this link suture. The second one is a horizontal mattress. This horizontal mattress will be pulled through a tunnel. You can see we're going to drill this tunnel. And then we're going to pass both the horizontal mattress suture and the single suture through. We do the second suture more on the periphery to keep this meniscus from extruding. We're going to tuck this flap in there. And this is still not enough in my opinion, so we're going to do a second all inside. This is a fiber stitch. And you're going to go from lateral and the actual root to the outer portion. And then you can sequentially tighten this. You can see that this is really a robust fixation, but necessary in these root tears as you want to get them to heal. And they'll do quite well in these ACL situations, better than in isolation. And these are more common and need to be understood. You do not want this root to be removed, as a lot of the root is taken out if you remove it. Again, you can see here we fix this nicely. And before final fixation, we're going to fix the ACL. So we're going to drill our pin with cannulation. And then we're going to pass our fiber rings. Here we're doing 35 millimeters. We've been modifying this technique as much as possible to get the best results. The 35 ends up being something that won't bottom out, but will really cover these larger ACL tissue. You can see here, this is a good shot. You can see the amount of vascularity. So we really don't want to take that out. And we've had excellent results in these patients. We've now passed the ACL repair device through both of the fiber rings. And you can see us sliding back and forth. To see other videos, look on my website. Now we're going to pass the button up through the cortex. We'll get an x-ray to make sure it's flipped. And we're making sure there's a little amount of suture in the notch. And then we're going to pull it up till it's almost tight. You can already see it's already at the wall. And now we're going to fixate the internal brace, which helps biomechanical strength. And then we're going to retension. You can see this pulls it back up to the wall. This is in figure 4. And now we have a really tight ACL with an internal brace to the middle, excellent quality ACL, repaired back. Something we would not want to remove in most situations. And we're going to do a Lockman. You can see it's completely returned. And then we're going to finally fix the root. And then we've done the MCL repair with internal brace, which is not shown here. And you can see that we're about 3 millimeters of gapping now instead of 6. So we feel really good about this, and we'll do a final Lockman to check it. Thank you.